Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Stand Medical Notes. So, we have discussed in the previous video about pleural effusion. So, we'll continue the further pleural pathologies. Let's begin with the name of Almighty. So, as you can see, we'll discuss about pneumothorax. What is pneumothorax? It is nothing but it is air in the pleural space. Air in the pleural space. Okay. Now, what will be the radiological signs in pneumothorax? So first radiological sign you will see is visceral pleural line, a thin white line representing the lung edge separated from the chest wall by black vessel free air. Important point, you will have a lung edge which is separated from the chest wall by a black vessel free air. So that is pleural line you will see in pneumothorax. Next sign is deep sulcus sign. So on a supine film, so when you take X-ray on supine film, air collects anteriorly and basally, making the costophrenic angle appear abnormally deep and lucent. So the costophrenic angle, so this is we are talking about if the chest X-ray is taken on a supine film, and that will make the costophrenic angle abnormally deep and lucent. That's why because air collects anteriorly and basally. So that's why the costophrenic angle appears deep and lucent. Lucent means with increased plaquishness. So that is deep sulcus sign. So this you will see in supine chest X-ray. Supine chest X-ray. And this you will see in PA wave. Okay. Okay. Let's see the X-rays. So signs of pneumothorax on chest X-ray show the lung edge. Visceral pleura. Lung edge is nothing but the visceral pleura is outlined by air in the pleural cavity. Usually a pneumothorax is well seen on a PA chest X-ray in inspiration. However, a small pneumothorax is better seen on a PA chest X-ray done in expiration. This is important. If the pneumothorax is small, it is better seen on chest X-ray, PA chest X-ray, which is done in expiration. Because of reduced lung volume in expiration, the pneumothorax appears larger. The pneumothorax appears larger because the lung volume is reduced in expiration. That's why the pneumothorax appears larger when the pneumothorax is small. Okay. Now see this chest X-ray. First see this. So exposure is okay, and yes, you see I think the patient, yes, it is equidistant, so there is no rotation. And calculate the reps: 1 2 3 4 5 6, normal inspiration. Now see both the lungs, divide it into zones. Okay, see the domes of diaphragm, they are okay. The left one is higher than the right one. See the hyla. See now the hyla of the left side is usually it is lower than the hyla of right side, but here you are seeing the hyla is also reduced. Now we have discussed that the bronchivascular markings are more on the medial side and lower side, more denser. If I cut this, so the bronchivascular markings are more on the denser on the medial side and on the lower side, whereas in contrast they are lighter on the lateral side and upper side. You should remember this. Okay, now you just see this. You're not seeing, you're seeing first upon a pleural sign. No, you're seeing this sign, this pleura. Okay, so if I mark it, so you can see it better. See this pleural line, see this one, see this. So this is the pleural line. Okay, and this is the hyla of the lung, which is now lower than the right hyla. Okay, so this is the pleural line. So this is the lung, visceral pleura. Okay, and that is one. The other thing is this part you're not seeing any bronchiovascular markings. So this is a left-sided pneumothorax. This is a left-sided pneumothorax, and it is not massive pneumothorax. Left-sided pneumothorax. So remember where, okay, I have discussed this in the topic. What we do is actually we calculate this distance between the rib cage and the margin of the collapsed, the margin, the pleural line. This is known as the pleural line. Pleural line. This is known as pleural line. Okay. So this distance, if it is more than 2 centimeter, then what we'll do is then it is called as large pneumothorax. Large pneumothorax. And if this distance is less than 2 centimeter, then it is known as small pneumothorax. Small pneumothorax. Okay. Small pneumothorax will resolve on itself. Large pneumothorax, so this will also resolve, but you need to give oxygen therapy, and if any infection is there, then you need to give antibiotics also. Okay. Okay. So same thing here, it is repeated in this right side. You can see, so this is the pleural line, and these asterisks are absent of the bronchovascular masking. You can see this bronchovascular masking here. So one thing we have noted, this hyla is, it has depressed lower side. Okay. Okay. So we will move forwards. Now we will see first the chest X-ray. You see here the chest X-ray. Okay. So check the technical quality. So okay, this is the trachea. Okay, and it is equidistant. It is equidistant, and the exposure is also okay. Exposure is also okay. And if you see the intercostal spaces, they are also okay. That means if you calculate the ribs, 1 and 3 ribs are not visible in this X-ray, but I think it is in good inspiration. Okay. So technical quality is okay. Now you just see here the hyla, the hyla you see here, you're not able to appreciate the hyla only here on the right side. Whereas the left side you can somewhat appreciate the hyla. Okay. So you can see the lung margin here. See, this is the pleural line here. This is the pleural line. Domes of diaphragm. Okay. So this is the pleural line, but here you are able to make out bronchovascular markings, but here you are not able to make out bronchovascular markings. Let's see what it is. Yeah, I said no. This is on erect chest X-rays. A small pneumothorax is typically seen at the lung apices. The figure above shows a small right pneumothorax, yellow asterisk. This one. This one. This is a small pneumothorax. Okay. After CT guided biopsy, so they have done biopsy, so that may be that pierced the pleura. That's why there was development of pneumothorax. So iatrogenic pneumothorax it is. So CT guided biopsy for a large mediastinal mass. Sorry from my side, it is not lung, it is a mediastinal mass. The right visceral pleura, pink line, this is the pleural line, is seen as thin line outlining the partially collapsed left lung. Okay. Now we will see the chest again. So this is a mediastinal mass. Mediastinal mass. Why? Because you are seeing the bronchomolecular markings here. So it cannot be a lung line. But if you see, observe this one, you can see some marking here, the lung line here, see. And at this point, compare both sides here with this. So here it is, the lucency is increased. Okay. So that is a small pneumothorax due to iatrogenic small pneumothorax, and it is not a lung line. I was making a mistake. So okay, so it is a mass actually. It is a mass, and we will learn about the mediastinal masses in the coming after this. The next topic is mediastinal masses only. Okay, this is a mediastinal mass, yes. And of course you see this, there is this is the aorta and this is the pulmonary artery. You are seeing filling of the aortopulmonary window also, enlarged aortopulmonary window, enlarged aortopulmonary window. Okay, you are seeing a enlarged aortopulmonary window also. Left parasternal stripe, you can see it is increased. Okay, so this is a mediastinal mass. They have done a biopsy, and that is so small pneumothorax usually this is important point, they occur at epices. Okay. Okay, now you see this chest x-ray. Yes, this is a supine chest x-ray. I may make mistake because I'm not directly interpreting those things. Okay, the mark things I'm trying to make out without looking at those things. So this is the scapular line. Okay, this is the scapular line. Okay, heart is not enlarged. You can see this costophrenic angle, this one, as a deep sulcus, as a deep sulcus. So this is the deep sulcus sign which we have discussed. Deep sulcus sign we see in supine chest x-rays in patients with pneumothorax. Okay, see the right hila. Okay, left hila is this one. So this is the lung margin. You can able to appreciate. This is the pleural line. This is the pleural line. This is the lung margin actually. This is the pleural line. Okay, this is known as the deep sulcus sign. When a patient on supine position and his X-ray is obtained, you will see deep sulcus sign. Okay, moving forwards. So let us see what. Yeah, same thing. See, I may make mistake. Okay, there it was actually a pulmonary mass. The same thing here. Deep sulcus sign, orange line on the left visceral pleura of the partly collapsed left lung. Left pneumothorax, yellow asterix. So this is the pneumothorax, increased lucency, and no bronchoscopal markings. Normal lateral right costophrenic angle. So this is normal. Yes. Okay. See this pink line. No, this is the lung line. This is the lung line, pink line. So that's about deep sulcus sign in pneumothorax. So we have seen visceral. This is nothing but pleural line. So you will see pleural line in pneumothorax and deep sulcus sign in supine position. Okay, and small pneumothorax usually they occur in apex of the lung. Now we will see something called as tension pneumothorax. This is massive pneumothorax actually, tension pneumothorax. So the patient will be very much breathlessness. So when the pathophysiology is one wall mechanism actually. So we'll read this one. So pathophysiology, a one-way wall effect where air enters the pleural space but cannot leave. What happens is the thing which happens is, so if this is the pleura and this is the lung, okay, so this will act as a flap. So what will happen is the air when it enters now, so it will be like this. I will just show. This is the pleura and here is the lung. So this is the flap. So while entering, the air will enter like this, but when it closes, when the air tries to move out, this flap will close and this is the air. Okay, so what will happen, the thing which will happen is more and more air get accumulated and it will not leave the pleural space. So it is very much, chest pain will be there, the patient will be breathless, and BP may fall. Okay, saturation will be falling. So immediately if you when you and what will so the thing will which will happen is unilateral silent hemithorax you will have, and the patient is very much breathless and the saturation is falling less than 90%, and you may have falling of the BP also. So then you suspect tension pneumothorax and just insert a large catheter in the second intercostal, this is the mid clavicular line in that, so that you can buy time to get the patient into a higher center, so that ICD can be inserted there. So this is tension pneumothorax actually. So pathophysiology is a one valve effect where air enters the pleural but cannot leave. Key sign is mediastinal shift away from the pneumothorax, and ipsilateral diaphragm will be depressed or flattened, and ribs are spread apart. This is opposite of collapse. So you need to differentiate between tension pneumothorax and collapse of the lung. So collapse will pull the structures, pull the diaphragm, pull the mediastinum, pull the trachea, pull the fissures. So everything will be pulling. But in pneumothorax, it will be opposite. It will push the mediastinum. It will push the diaphragm. It will push the fissures. So this will happen in tension pneumothorax. Okay. So now signs of tension pneumothorax: the mediastinum is displaced away from the pneumothorax, the diaphragm is depressed, and the distance between the ribs is larger. Whereas in case of collapse, the side at which the collapse is present, the ribs will be crowded at that side. Okay. You are seeing something, I think these are some sutures or something. These are not vertebrae, these are some sutures. Okay. And you can see, clearly you can see the scapula here. Okay. This is the scapular line. You're not able to see hyla only here, not able to appreciate hyla only. And this is very clean lung, and you can see the trachea here. So the mediastinum is shifted towards the left side here. Okay. And the heart is also somewhat shifted to the left side. Bronchopulmonary markings are present here, but here you can notice, so this is the pleural line, lung line, pleural line, and this is the pneumothorax hole. So when you call it as tension pneumothorax, the mediastinum will be shifted opposite side. And if you see the dome of diaphragm, see, normally the dome of diaphragm, right side it will be higher than the left side will be higher than the right side, but you see in this picture it has become flat, and lower than the right diaphragm. So this is tension pneumothorax, and you are seeing you are able to see increased lucency here. The lucency is increased, and the space between the ribs, indicating hyperinflation. The space between the ribs is also increased. If you can count the ribs, 1 2 3 4 5 6 7 8 9 10, 10 ribs are there. The space between the ribs is increased. Okay. So this is a case of tension pneumothorax. So the main point is mediastinum is shifted, dome of the diaphragm is depressed. Mediastinum is shifted and dome of the diaphragm is depressed, and the ipsilateral ribs will be the space between the ipsilateral ribs will be increased. So same things is shown here. Okay. So this is if I read, I said no, these are some sutures. So these are yellow asterisks, tension pneumothorax after cardiac surgery. So these are the sutures of sternotomy. These are sutures of sternotomy. Okay, sternotomy sutures. The right lung is entirely collapsed. Yes, this is the collapsed lung. Okay, total lung collapse because of not pleural effusion, but because of not fluid, but it is because of air. Passive collapse of the total lung collapse. But in collapse, you see pulling of structures. Here you see pushing of structures. Okay, that's how you can differentiate between collapse and pneumothorax, tension pneumothorax mainly. The right lung is entirely collapsed. Shift of the mediastinum to the left. Note the right cardiac border, dark red line, projects medially of the right paraspinal line. Expansion of the right hemothorax and increased distance between the ribs. Okay. At the right hemithorax, inferior displacement of the right hemidiaphragm in comparison to the left diaphragm. So same things. Okay. So this is tension pneumothorax. The last topics in the pathology of the pleura is the pleural plaques. Okay. So what is the pathophysiology? There are discrete means separated. Discrete areas of pleural thickening. The pleura will become thick. Key sign, the most common manifestation of asbestos exposure. Appearance often calcified, typically affecting the subdiaphragmatic and lower chest pleura. Okay. So we will see now. Pleural thickening. which corresponds to thickening of the visceral or parietal pleura. It can occur because of infection like tuberculosis or pleural empyema, pus in the pleural cavity, or trauma, complication of hemothorax, or it can be a manifestation of pleural plaques or of pleural tumors. Pleural plaques are the most common manifestation of asbestos exposure. Neoplastic conditions causing pleural thickening include pleural mesothelioma, pleural metastasis, and tumors with secondary pleural fissures. What are the causes then? Number one is infection, most common, tuberculosis and bacterial empyema. Number two is hemothorax. Number three, you can take it as tumors or asbestos exposure. You take asbestos, pleural plaques. Number four will be tumors, pleural mesothelioma or metastasis or secondary pleural effusion. Most commonly pleural mesothelioma. Okay, so these are the causes of pleural plaques. So signs of pleural plaques on chest x-rays, they include pleural based convex soft tissue opacities when these are perpendicular to the film or detector, and poorly defined opacities when these are parallel to the film or detector. So holy leaf aspect, so this is a sign which you see in pleural plaques. Holy leaf aspect, what is that? Irregular and thickened plaque edges. Calcifications, blunted costophrenic angles. The differential diagnosis includes pleural effusion. However, most often the costophrenic angles and apical pleura are spared by pleural plaques. The most common area affected is the the lower side, the pleura which is present at the dome of diaphragm. That is the most common site. Okay, so these are the two different x-rays. One by one we'll see. Here you can see a large pleural plaque which is present on the right side of the chest. Okay, so large calcified plaque in a patient with previous history of tuberculosis. So this patient had tuberculosis. So this is the second what do you call x-ray. So patient with asbestos exposure and calcified plaques along the diaphragm, anterior and posterior pleura and lateral pleura. The left lateral plaque shows soft tissue thickening and calcification. So this is a patient with asbestos exposure. Most common important thing is calcification which is present on the dome of diaphragm. You can see this, no, this yellow arrows, and on the ribs, this is the posterior pleura. And okay, more commonly you see on the dome of diaphragm. You can easily appreciate at the dome of diaphragm. This is due to asbestos exposure, and this is in patient with tuberculosis, and this is asbestos exposure. Okay, so that's about, by this we complete the topic of pleural pathologies. So from the next video we will continue about the pathology of mediastinum and hyla. Thank you for your listening.